Title of my talk is practical guide. I know that's what everybody needs, and I love menopause, and you can too. And I put that because nobody loves menopause, including the menopausal patient. So we all understand we're in the same space, but we at least should try not to be sort of overwhelmed by it because it's such an important topic. I was telling, why can't I advance my slide? Sorry. Okay. I was telling Julia that every time I do this talk, I have a really hard time reducing the number of slides. So I have a lot, so I will probably go quickly. And I do apologize for that. But, I think the slide set can be available for anybody who wants it. These are the learning objectives for today, looking at definitions, terminology, symptoms, obviously hormone therapy and other therapies for menopausal symptoms, risks, and alternatives, and long-term benefits. Um, so just a reminder, menopause occurs, it's defined by 1 year after the final menstrual period, and because the ovaries cease to function. Usually the average age is 51, but it can occur from around 45 to 54. By definition, if somebody is going through menopause before age 40, it's considered premature. And of course, menopause can be induced by either removal of the ovaries or damage to the ovaries with chemotherapy, radiation. And all of these patients will, uh, have similar symptoms, some worse than others. If a woman is still menstruating after age 55 or 56, she's at increased risk of uterine cancer. And so those patients need to actually have uterine biopsies. Just keep that in mind. Some of my patients have been in their 60s before they stop. The menopause transition is who knows how many years it is, but it's around the time of the final menstrual period, maybe a couple of years before, a couple of years afterwards. It starts with variation in the menstrual cycle. Nothing is predictable here. They can be all of a sudden, it can be gradual. And there are a lot of other things going on at this time of life that aren't caused by menopause, although many women, especially now with a lot of attention on this, feel that pretty much every symptom they have is attributable to perimenopause or menopause. Keep in mind that these patients can still get pregnant. We have seen them. So if until they've gone a full year, and it's not so much even their lab tests, it's they have to be a full year after menopause before you can tell the patient that she doesn't need to use anything anymore. And this is really the hardest time for women. Things often get better after the transition. This slide just reminds us that women starting, as the average life expectancy has gone up, we spend some people, it's like probably more than two-thirds, like half, one-third to two-thirds of our lives in menopause. So this is extremely important because it has such huge impacts. How do you confirm menopause? Based on their age, their medical and menstrual history, and their symptoms. I only get labs if I have a patient who's very young, um, and I'm not sure if that's what her problem is or if there's something else going on. So if she's amenorrheic, for example, I will check a thyroid, prolactin, and you would only do serum levels, not salivary. We'll talk a little bit about the whole naturopath world of trying to check hormone levels and titrate their hormones. There's no evidence to say that that's of any value at all, so you don't have to worry about getting levels. And this just shows us that around the final menstrual period, within 2 years, the FSH goes up, the estradiol goes down, and it stays there. And we do not titrate hormone therapy to estrogen levels ever. And patients often are confused about that, but we titrate them only to symptom relief. So you don't need to check levels like you would for thyroid, for example. So the most common presenting symptoms, this is the list, and my advice is to focus on the one that or two or four that are bothering the patient the most. Some people come in with all of these things, and if you don't ask about libido, for example, they might not tell you, but this is why this is such a fun time in our lives, right? Our changes in menstrual cycles, the vasomotor symptoms, sleep, insomnia, huge, brain fog, memory, mood changes, irritability. I don't like myself. I don't feel like myself. Everybody hates me. No libido, pain with intercourse. Some patients, do have joint pain, frozen shoulder. That hasn't been much of my experience for my patients, but it has been reported. So your patients coming in, having changes in their period, what do I do? They could be lighter, they could be heavier, they could be all over the place. And so mildly irregular means they start to space out. Mostly you like to see them space out, get lighter. That is the typical pattern for a perimenopause, menopause patients. When they start having more bleeding, more frequent, their periods last longer, or and they're heavier, there could be something else going on that needs to be evaluated. So patients will say, "Oh, I'm just in menopause," and their hemoglobin is 8. Well, that's not a normal uh, symptom. They should be able to tolerate changes in their bleeding pattern, but if their hemoglobin is low, then that means they're kind of hemorrhaging every month. So that needs to be worked up. Um, the main thing to do, and I apologize if you know some of these things already, but I'm just going to go over the ones that I think are most important. If a patient comes in with abnormal bleeding, she's menopause, post-menopause especially, please examine her because she could have a cervical polyp, she could have other lesions, there's other things she could have just on her exam. And on the ultrasound, the endometrial echo needs to be actually less than 4 millimeters. Um, in order for you to say definitively she does not have cancer. She could have something else, but you know she doesn't have cancer, and you can continue to observe and monitor. If the bleeding continues and doesn't get better, then that's when you would refer. So the first question, I just have a couple. This patient is 48. Her periods are coming every couple of weeks, lasting 9 days. She's getting symptomatic with hot flashes and sweats. She's no history of any other issues. And she's already had an endometrial biopsy. Anybody over the age of 45 who has abnormal bleeding should have a biopsy. So that's something you would refer to. So what would be my first choice for treating this patient? Progesterone, cyclic, meaning 10 or 12 days a month, an IUD, hormonal contraceptives, or hormone replacement therapy. And the answer here would be hormonal contraceptives. You can do all of these things, but she's symptomatic from menopause, and so the hormonal contraceptive has estrogen as well as progesterone to support the endometrium and give her symptomatic relief, but she's not over the hump yet in terms of being menopausal. And if I started her on hormone replacement there, she probably would continue to bleed all over the place, but I want to establish regular bleeding for her. So for perimenopausal women who are still getting their periods, this is my number one choice. For management, the main contraindication is if they smoke. And these other contraindications are pretty obvious: high blood pressure, not uncontrolled high blood pressure, diabetes. Obesity is maybe relative. I don't know that I would not give somebody the pill because of that. And the most important is if they're at increased risk for VTE. But this works very well. And so then it suppresses the symptoms, restores the bleeding to a predictable pattern. Their pain decreases. It's associated with enhanced bone mineral density, and they have a lower lifetime risk of uterine and ovarian cancer. So there's a lot of benefits to it, including symptomatic relief. So how long can they stay on it? Well, as long as they want to. So there's no magic number. I've had patients 50, 52, 54, 55. We talk, and what I don't want to do is take them off in the middle of transition and then they start all over again. I'd like to pretty much get them to the other side so that if they want to transition from birth control pills to hormone therapy, it's not so dramatic in terms of their symptoms. Um, and so this is pretty much how I approach it. Once they stop the pill, because it's a much higher dose of estrogen, and go down to hormone therapy, they can't get symptomatic, and you just sort of have to manage that. So terminology, you know, so we don't say hormone replacement therapy anymore. The Menopause Society, or these societies dictate all of the language, and sometimes it's not that useful, but this is what it is. It's menopause hormone therapy. We don't call it HRT anymore because we're not replacing hormones to their physiologic levels pre-menopause. So that's why they changed it. There's estrogen therapy. What we mean by that is estrogen alone. And that's really only for women without a uterus. If a woman with a uterus takes estrogen alone, she will get uterine cancer. So that group is for women without a uterus. Estrogen and progestogen therapy, EPT, is when, the combination. I have been, an OBGYN for 30 years. I do not know the difference between I don't know why, but anything with a P, just know that's a progesterone derivative. And then bioidentical hormones is just things that are hormones that are chemically identical to those made in the body. And the ones we use, everybody's prescribing are FDA approved, but patients still have some thought that, oh, I need bioidenticals, they're going to be better. And that is what we end up um, prescribing anyway. We can't talk about hormone therapy without talking about the Women's Health Initiative because that's what set us up for where we are today. This was from 1991 to 2005. And the two questions asked, this was done by internists like medicine. It wasn't studied by OBGYNs. And they were asking the question, does hormone therapy decrease coronary heart disease and osteoporosis related fractures? And does it cause elevated breast cancer risk? And so they set their bars in terms of how, if they got to a certain point, if they would stop the study. Later, they've looked at stroke, PE, cancer, hip fracture, and overall mortality. So they divided them into two groups. And keep in mind, at the time, the main form of estrogen was Premarin. Conjugated equine estrogen comes from the urine of a pregnant horse. And medroxyprogesterone acetate, which is the most common if you ever give Depo-Provera shots, Provera, that's what that is. So the women with the uterus got the estrogen plus progesterone. The women without just got estrogen alone. And they took anybody between the ages of 50 and 79. This is where the problem is. Oh, sorry. So they didn't look at anything related to quality of life. They only used these formulations of hormones. And they didn't look at any other type of hormone, any other way of taking it. And the average age in the Women's Health Initiative was 63 years old. So women were starting in their early 60s, having never been on hormones before. And so only less than 4% were at the onset of menopause, 50 to 54. And this is why became a huge issue. So what they found was they had to stop the study at 5 years for the estrogen progesterone because they just hit their threshold for breast cancer risk. And they found there was increased risk of breast cancer, heart disease, stroke, VTE, what we would expect, decreased risk of osteoporotic fractures, and decreased risk of colon cancer, which people don't talk about much, but it's important. The estrogen arm lasted a little bit longer. And what's really interesting here is that these patients had decreased breast cancer, which is sort of counterintuitive because we always think of cancer as having estrogen progesterone receptors, but it's consistent that women who take estrogen alone have lower incidence of breast cancer, obviously better in terms of bone loss, decreased colon cancer, no effect on heart disease, but they too had increased risk of stroke and VTE. So I had started practice at that time. Patients came in throwing their hormones down the toilet. They were suffering. It was in the summer. The people who wrote this appeared had a press conference talking about it before it was published in the New England Journal. We were caught by surprise. Patients' cardiologists were telling them, you better stop everything. And then, everyone stopped giving hormone therapies. So this just shows the benefits versus the risks in a graphic form. But I thought this was helpful. This came from Up to Date in terms of how you might counsel a patient. So if they're on combined therapy, this is, how many more cases per 1,000 women for 5 years are there? 3 cases of breast cancer per 1,000 women in 5 years. That's not a lot. It's a slight increased risk. It's not huge. And so this is one way way you could counsel the patients. The all-cause mortality consistently is lower in women on hormone therapy, estrogen or estrogen alone. Similarly, for estrogen alone therapy, this is again how you could counsel a patient. It's what's in that graph, just in descriptive form here. But as a result of the Women's Health Initiative, there's now a black box warning for hormone therapy. It doesn't matter who, doesn't matter what, doesn't matter which brand, but it just warns patients there's adverse risks such as cardiovascular disorders, cancer, and probable dementia. So like I said, they lump all of the products into one, which is a problem. But over time, multiple studies were done, different analyses of the Women's Health Initiative, and they realized that the patients who were older and started were the ones who had the biggest risks. And women who started hormone therapy within, 10 years of menopause actually had benefits. And they're continuing to look at it. Most likely, they will be the ones to have like cardiovascular benefits and so forth. And we'll talk a little bit about that. But this is the timing hypothesis that if you initiate it in early menopause, you have a reduction of CHD by 48% and all-cause mortality by 30%. And so this, I'll tell you, this was an article that a patient who's a professor at USC brought to me because she was really afraid I was going to take her off her hormones. She had been on them for probably 15 years, and she brought this article written by somebody at USC to tell me about all the benefits, which I told her it's fine, you can stay on it. And that the issue of stroke risk, for example, is really at initiation of hormone therapy and especially in older women. Diabetes onset is decreased. These are things people don't often think about. So the timing should be within 10 years of the onset of menopause or younger than age 60. However, there's also been some discussion of like, are we really stuck with this window? And if you're outside of it, is it contraindicated? So there's been some reviews that talked about restricting the initiation of any hormone therapy to women younger than 16 within 10 years of menopause is overly cautious. Rather than this strong chronological focus, individual risk factors should be the primary consideration when discussing the benefits and risks of initiating. This is going to be the main theme of everything is individualized. There is no ever one size fits all for patients, which makes it hard for us, but it is what it is. So you don't have to stick within those parameters if the patient wants it and understands the risks, then you can discuss it together in a shared decision-making model. So the contraindications to hormone use where I wouldn't even ever, no matter what the patient says, entertain it or think about prescribing are these. History of breast cancer, coronary heart disease, previous VTE, probably somebody also with factor V Leiden, I don't think I would give it to. Active liver disease, unexplained bleeding. I mean, I'll figure out the bleeding and then I'll give it to them. It says high risk endometrial cancer, meaning high risk for like metastases, advanced stage, because if they have early low-grade endometrial cancer and you take out the uterus, those patients could probably take hormones. TIA. So smoking isn't on here. It's a contraindication for birth control pills, but I've seen patients told they couldn't take hormone therapy because they smoked, but it is not a contraindication, again, because it's a much lower dose. So talking about breast cancer, this is probably the main thing that patients are really afraid of and why they don't take it, no matter how you explain it to them. But the issue is the progesterone. So when you, in the patients who took both estrogen and progesterone, that's where you had higher mortality, increased number of cases. But again, what's the number? 8 excess cases per 10,000 person years after 5. I mean, that's the increase, and that's how you counsel the patient. But the estrogen alone arm of WHI showed no increased cancer risk after 7 years, and there was a significantly decreased risk of breast cancer after 7 years, which persisted after discontinuation. This is really important. People do not always think of this because it might not make sense, but women on estrogen alone, women who don't have a uterus, have a lower incidence of breast cancer. Um, and what causes it is the progesterone. We can't avoid the progesterone because that protects the uterus from uterine cancer. But the hormones do affect cell proliferation, density of the breast, and so there can be difficulty sometimes interpreting the mammograms. And that once people stopped hormones, their breast cancer risk declined after about 3 years. As I mentioned, endometrial cancer is important because I have seen patients who've been started on estrogen and somebody forgot to give them progesterone and they've come in with precancer, cancer of the uterus. So if they have a uterus, they have to take progesterone. You know, and if they have had early stage endometrial cancer and want to take hormones, I probably would leave that between them and their oncologist. As far as coronary heart disease, I believe that, we're going to see more and more data that does show the reduction of CHD in women on hormone therapy. So just more to hear on that. But you can't give it in order to protect against that. It's not indicated for that, but that will be, to me, a result. Stroke is increased, especially in the initiation of hormone therapy. It seems to get less right afterwards after a year or two, but using transdermal estrogen does not increase the risk of stroke, which is why that's always the preferred choice to start with. For cardiovascular disease, you all probably know more about this than I do in terms of calculating their CVD risk over time. and when it's okay to whatever calculator you use to give hormone therapy. And this to me is a little bit of a kind of a dog slide because the high risk patients, when you look down here, it's like, oh, known MI, stroke, peripheral artery disease. Like, why would you have to look that up? You just wouldn't give somebody like that hormones, and everybody else, you could think about it and talk to the patient. Um, for VTE, like I said, lower risk for transdermal and maybe lower hormone doses. It's higher risk in patients who are obese with factor V Leiden. Again, something to think about. But it's not a reason to withhold hormone therapy, for example, from obese women. That would really be terrible. Um, so the FDA then says, here are the indications for menopausal hormone therapy. Vasomotor symptoms, prevent osteoporosis. That's it. There's all these other benefits, but this is sort of what the FDA says. So of course, as doctors, that's fine, but we will know what we do. We just go on and find all these other things we can do with it. So talking about what hormones do and what they help, the number one thing is vasomotor symptoms, that sense of like your whole body getting hot. People can have them, every 2 minutes. Sometimes they'll get them. A patient said the other day when somebody starts talking to her, really inconvenient, really terrible time. And happening at night, then they just can't sleep. And this occurs during the perimenopause. Some women, about 20%, will continue to have hot flashes their whole life if they don't take something for them. But it is this sort of increased body temperature. It doesn't matter what a person's hormone levels are. They, it doesn't correlate, so we don't check the levels. Um, but it is something, and what's important also to realize is that the duration is longer for women who are African American and Hispanic. So those patients can have more intense and symptoms during this time. Um, and there's environmental factors, food, other things that can also cause hot flashes. So it's something to look at the whole picture to see what else could be going on. How do we treat it? It really depends on what the woman wants. The best treatment is hormone therapy. The body is craving estrogen at this time. There are other different things people use, dietary supplements like phytoestrogens and so on, herbal remedies. Those have not been shown to be effective, although they might help in really mild symptoms. But why not? They don't hurt if the patient wants to try that. But at the end of the day, it's estrogen. So if they have a uterus, estrogen plus progesterone, and if they don't, estrogen alone. There are other medications. Breast cancer patients wouldn't be taking hormone therapy, so they've looked at other things that will help. And the most commonly used ones are the SSRIs and SNRIs, gabapentin, and now the neurokinin receptor antagonists. Fezolinetant, which is Veozah, is out, but it has an issue with causing elevated LFTs. And there was just an article in New England Journal talking about another product that probably will come to market soon, which doesn't change the LFTs. And this is a really great uh, advance for patients who have severe vasomotor symptoms and cannot take estrogen. This just shows you that the reduction compared to placebo with venlafaxine or gabapentin. And what often goes hand in hand is sleeplessness. Insomnia is one of the biggest problems. Sometimes it's because of the night sweats, and a lot of times it isn't. The patients often report waking up at 3 or 4 a.m. and they cannot go back to sleep. And this is sometimes one of the biggest problems when patients come. If they have night sweats, it's easy. I put them on hormones and they get better. But for the people who just wake up for no reason and they didn't before, we have to find other things that will help. We always look at other things related to it. It's a big issue. I'm sure you deal with insomnia probably more than I do. But as far as perimenopause, this is where it comes in for me. We have had patients also who ended up being referred for sleep studies and had terrible obstructive sleep apnea. So it's not always the menopause, even though patients want to think that. There's again other things that can be going on that could be causing them. So we just have to pick apart the whole picture. So again, nothing's been approved to treat insomnia, but it does help. And so, especially by decreasing hot flashes and sweats, the micronized progesterone, which is the one we prescribe most commonly, also causes sleepiness, and that really helps people sleep as well. Gabapentin is often used, whether or not it's helping with the menopause symptoms, just to help with the quality of sleep. Patients have concerns, though, about long-term use of gabapentin on brain health. Magnesium definitely has been shown to be helpful in sleep hygiene, all of the things I'm sure you all look at, but this is where we, from the hormone perspective. Cognitive changes. I really want to believe that being on hormones will help prevent dementia, Alzheimer's, and improve cognition, but the data does not support that. It does help early on in perimenopause in terms of, mental acuity, verbal memory, and so forth, improvements in mood. And I believe I approach it where most of my patients, I attribute some of their brain fog and those symptoms to not sleeping. They have very disrupted sleep. And if we can start by fixing the sleep, then we can look at this issue afterwards. And most of the time it gets better. The other issue too is that vasomotor symptoms are constant firing in the brain. Think about that. So that can also then, affect cognition and really be a problem for these patients. So that's another reason, not just to treat the vasomotor symptoms because they feel terrible, but because they are probably having a negative effect on their brain function. So this is important. Even if you started in the critical period we talked about, there's nothing that says it's better or worse. The issue is for women who are older and already have dementia, hormone therapy has shown to accelerate it. So that is a contraindication for anybody who actually has dementia. And again, the bad drug here, medroxyprogesterone acetate from Women's Health Initiative, seems to be associated with more negative effects in this regard. Mood disorders, this is a big one too. Patients come in, I'm irritable, I'm angry, I have mood swings, I'm upset all the time, I don't feel like myself. Is this depression? Is this anxiety? Is this menopause? Very difficult to sort out, but it takes time to really understand. But women who are at risk for depression have a higher risk of depressive symptoms during the menopause transition. There is evidence that estrogen has antidepressant effects in perimenopausal women, especially those with vasomotor symptoms, again, pointing to probably the effect on the brain. So in combination with SSRIs and SNRIs, it could be helpful. But with estrogen plus progesterone can cause more irritability and mood changes depending on the type. So there's no easy answer here, but sometimes women come in wanting hormones for this reason. And here's all the reasons why. We're all stressed out at that time in our life because we're getting older. People who couldn't have children now, it's permanent. Medical problems, marriages falling apart, their kids have left, they're taking care of kids, they're taking care of parents. They're, peak of their career and maybe not. And a lot of women, it's just like they don't feel good about getting older. We live in a society that's biased against aging, especially in women, and so they're biased against themselves. And this contributes to it. The weight gain. The weight all comes here in the belly. It's the visceral fat. So that women are like, I just feel like I'm a big, large sausage because all of my weight is here. And it just happens gradually, especially for people who aren't used to having to watch their calories. And they will put on 10, 15, 20 pounds, and then they can't lose it no matter what they do, unless they go through into an extreme calorie deficit. The biggest advance now is the role of GLP-1 agonists in combination with hormone therapy. Hormone therapy has already been shown to help with weight stabilization, possibly weight loss, but to really lose the weight that they've put on, they need extra help. And it can't just be diet and exercise. It doesn't work for the menopausal patient, which is tough. We know that hormones will help with osteoporosis. I just added this in here just as a reminder. But keep in mind, as soon as people stop taking hormones, their bone loss starts to go up. It makes your skin dry. You start to grow hairs on your face and lose hair on your head. Your eyes get dry, your vision changes. You can't hear anymore. This is the part in the talk where I just get really depressed and just want to stop, And it's a cruel joke on women when your eyesight starts to go, the chin hairs begin sprouting. When your daughter leans across the table at a restaurant to pick out a chin hair, then you've passed that threshold. Last issue we're going to talk about are vulvovaginal symptoms. Again, next question here, 55-year-old woman who has done chemo for breast cancer. She's having terrible symptoms, hot flashes, severe dryness. She is sexually active and wants to stay that way. And vaginal lubricants and moisturizers are not working for her. So what will help? More lubricant, oral estrogen progesterone, transdermal estrogen, vaginal estrogen. And the answer here is vaginal estrogen. Regardless of the fact that she's had breast cancer, study after study shows that using topical estrogen in the vaginal area does not increase the risk of breast cancer recurrence. The oncologist will reinforce that. And what's happening is that the vaginal epithelium is becoming atrophic. I think they changed the name to genitourinary syndrome of menopause, which is a mouthful because nobody wants to think that they're becoming atrophic, but that is what it is. And this can cause dryness, irritation, itching, painful intercourse, and this happens more as the estrogen levels are down for a while, not right at the beginning of perimenopause, and it will get worse over time. So the lower the estrogen, obviously the higher the pain, and it's pain, burning, all of those things. It's kind of an obvious thing. Women who take systemic hormone therapy often will have improvement in this area without having to use vaginal estrogen. Regular sexual activity promotes blood flow using lubricants during intercourse. Vaginal moisturizers, high hyaluronic acid is our favorite right now. There's these other products that I don't prescribe at all because they're so expensive and insurance doesn't cover them, but they do help. And mainly vaginal estrogen, low dose, where you insert like a gram or half a gram twice a week of a cream. It comes in other forms too. And then really important, pelvic floor physical therapy for painful intercourse. This has been a huge big game changer for patients who really thought they could never have sex again. And then going through the physical therapy along with the vaginal estrogen has really changed their lives. Bladder complaints, incontinence becomes more common. It does seem to get better as they get older, interestingly, but these other symptoms like urgency, dysuria, frequent UTIs, that's all part of the genitourinary syndrome. You do have to look for other causes, though, just to be complete. And then this is helped again by systemic hormone therapy, weight loss, vaginal estrogen, and especially pelvic floor physical therapy. And if none of that works, then they get referred to a specialist for possible surgical intervention. Sexual health. Oh yeah, this is my last topic, but probably one of the most important because this women are in midlife. Many of them are still, in a relationship or want to be, and this is a big part of it. So many women report decreased libido. They'll say things like, "I don't care if I never have sex again, but I'm married, and this is not good for our relationship." They can have other symptoms. They may not feel attractive. Women in general still consider sexuality important throughout the lifespan. But there's all these different things that can happen that will affect their sexual health. They feel disappointed that they don't want to have sex anymore, and they don't have the desire, and they feel less desirable due to body changes, weight gain, hair loss, skin changes, and so forth. And this can lead to depression, challenges at home, problems in the relationship. And so, end up kind of being a marital counselor for some of these patients because they don't necessarily want to talk about this in the setting of counseling. These are sample questions you can ask if you're not comfortable talking about this with your patients, or you could put it in a questionnaire that you give when they come in for their visits, but it is worth talking about. This is just a reminder of the sexual response cycle, and all of it's interrelated and connected. And women can have problems at any point in this, in terms of even just sexual arousal itself, being able to achieve orgasm, vaginal lubrication, and then all of that affects, the relationship itself. And then there's all these other issues that can have an impact negatively on woman's sexual interest and function. And so it's a lot, but that we still have to address it. Sometimes when you do address the vaginal dryness and painful intercourse, then they are not afraid to have sex anymore. Hormone therapy doesn't increase libido. It does help with sleep, which can help with fatigue, which might make things better. And it does enhance skin sensation. So the low dose estrogen, again, is helpful for people who have vaginal symptoms in particular. But nothing else helps decrease libido except testosterone. And of course, why would there be any approved testosterone therapy in America for women? There isn't. And so you have to use male testosterone gel or testosterone from a compounding pharmacy, and the data is mixed about whether it actually works. There could be sort of a strong placebo effect. And it's expensive, not covered by insurance. There are these other products that I don't use because of the side effects, and sort of they're weird, like 45 minutes prior to the sexual encounter. So these are there, but I don't use them. You can do all these other things that help. I'm Palestinian, so of course we believe that olive oil is the cure for everything. And if it helps with libido, why not? It helps with so many other things as well. But the Mediterranean diet literally has been shown to be of benefit in this regard. And one of the most important things is variety. And one study years ago said that the biggest thing that could change a woman's sexual desire and interest was change of partner, which really isn't a practical approach to decrease libido, but the need for variety and stimulation is important. So how do you give hormones? So we talked about transdermal as being the preferred. It's 17 beta estradiol, which is bioidentical in a patch. I do not use the 0.025 patch because it's too low. And for women who are really symptomatic, I find that it doesn't work, but a lot of people are really conservative. I just start at 0.05, and then I give them micronized progesterone, 100 milligrams at bedtime. Sometimes I'll go up to 200 if they start having some spotting. You can also just use oral estradiol if they don't want to use a patch. And these are other types of progesterone. One that's become more popular is using the like Mirena or levonorgestrel IUD. Of course, it's off-label, and you have to change it every 5 years. There's patches and pills that combine estrogen and progesterone. The patches that do that are not hard to find anymore. Um, there's also pills that combine. They're cyclic. Like you can give hormones, estrogen for a month, and then 12 days only of progesterone, but that will precipitate a period. So I don't do much cyclic progesterone prescribing, except maybe around the period, women are still menstruating. And then the combination of estrogen progesterone in a pill, and these are variations of different birth control pills just at a menopause dose. So this can be very convenient. Conjugated equine estrogen, I do not prescribe for ethical reasons, but some insurances only pay for Premarin. So I will prescribe it, but I prefer not to. What type of progesterone? You have to do it if she has a uterus. Um, Avoid medroxyprogesterone acetate. Micronized progesterone is our first choice, and then levonorgestrel is a good idea, the IUD. But the other progesterones are all approved, whether it's norethindrone or drospirenone. So they are out there, and they are approved for hormone therapy. Vaginal estrogen occurs as a cream, as tablets, or as a ring. This was great, the ring every 3 months, but there is no generic, so I don't prescribe it anymore because it's very expensive for patients. The tablets, they like them because these applicators are disposable each time. For the cream, they have to wash it every time in between use, and it's messier. Again, but if you go onto the formulary, a CAC and Cerner, and you're like, oh, I'm going to choose estradiol cream, so many of your patients on Medicare, all of the products will be non-formulary and maybe one or two, either or. So if you can't even choose between them, you have to only choose what they provide. And some insurances don't cover any vaginal estrogen products at all. So the bioidentical question is really just one, to talk to your patients about, the naturopaths who check hormone levels and then titrate their hormones. That costs a lot of money for these patients. There's no evidence to show that it's a benefit, but I think patients like that idea. But the hormones we use are bioidentical, and so you can reassure patients. There are people who are putting pellets in patients' arms of estrogen, progesterone, testosterone, which we uh, do not recommend because the doses are very unpredictable. So, and again, it's a cash procedure. So how long can you give somebody hormones? My basic answer is as long as they want. So if they ask you about breast cancer risk, I tell them, yes, the breast cancer risk will go up the longer you're on it. If you're taking estrogen alone, you have lower risk of breast cancer. I talk about these benefits with early use, like we talked about, all-cause mortality decreasing. Um, and then, and then it's really up to the patient. So some patients are on it for prevention of osteoporosis or because they can't take anything else for osteoporosis. But if they decide to stop, you have to taper slowly or they will have rebound in symptoms. So I recommend if you start somebody on hormones, checking in with them 3 months later, it could be a telemedicine visit, If they start bleeding because their body's not used to having hormones on board, you know, if it doesn't stop, get an ultrasound. If the endometrial stripe is greater than 4, refer them for biopsy. If it's less than that, you can just maybe bump up the progesterone level to see if that stops it. And if they keep bleeding, then they need to be seen. I always tell them I reassess at each visit, so I never tell them this is forever, maybe just for this year. And I don't ever check hormone levels unless something is really unusual about that patient, or if I had her on testosterone, wanted to follow. So for every patient, everything is different. The basic approach is transdermal estrogen with oral progesterone. I start at like 0.05, but you can start as low as 0.025. You have to look at the benefit risk profile for your patients, and most women in this age group, it's pretty low. Um, and so there's really a lot of flexibility in my opinion. So our last question is the 66-year-old patient who came to me and she wanted to go on bioidenticals. Started out saying because for her heart, osteoporosis, her hair is thinning, she's gaining weight, and hoping they will help her. She has had a history of what she thinks is angina, but not sure. She takes Lexapro, and then at the end of the visit, she says her husband just left her for a younger woman to start another family. So this is a much bigger problem than hormones. But what am I going to say to this patient? So I said, okay, if this is what you need to feel like things could get better, why not try it for 3 months? Nothing's going to happen. She's older. There are risks. Is it an absolute contraindication? No. I tell her I don't know that any of this will get better with hormone therapy. But if she really wants to, I would do it for like a 3-month period and then try to encourage her to do other things to help with her situation. So this time is so important, takes a lot of time to do. I mean, I covered a lot, but there's a lot here. I think not a lot of doctors or providers can really give the attention these patients need. There's definitely a bias against older women in general. And a lot of doctors were trained to avoid hormone therapy, so have a fear of it. Like, I'm going to cause cancer. You can't take it. I don't want to take it. You're going to get a heart attack. You're going to get a stroke. So I've seen that on so many levels. So we need to just move away from that. And a lot of women are coming in their 60s feeling that they were shortchanged since no one would prescribe hormones for them. But this is a huge market, and that's probably what's going to drive advances in menopause. Hopefully, they'll come up with something for libido. So, Dr. Donna Shoup is the expert in our department. She did a great talk for the endocrine department at Keck, which you can see on View Medi on hormone replacement therapy for menopause. I would highly recommend that. The Menopause Society is really the go-to organization for this topic. MIDI Health, so don't get mad at me, but you don't have to take care of this at all. You could refer your patients to MIDI Health. They do have a contract with Keck, and there it's run mostly by nurse practitioners with expertise in this area. So if you feel like you've done what you can and they really need more care, it's all telemed, but it is a service that we have recommended even to our patients. The patients are going to get all kinds of information themselves. They're going on the internet, social media, reading books, and these are some of the better resources. I just put influencers on social media because that's what they do, and they come in and ask you about your opinion about it. But these are some that you could recommend to your patients. That's it. I'm sorry I talked so fast, but hopefully it was useful to you. And I guess if we want to do questions, Julia, or what's the next step?
Sure, sure. Oh my gosh, thank you so much. That was so thorough and entertaining and awesome. Really appreciate it. Um, well, we can take some questions if that's okay with you.
Sure.
And I would
Mhm.
like to everybody just to look in the chat again to get CME and MOC credits. Dr. Hong did write a question in the chat, so I was just going to read it if that's
Yeah.
okay with you. I have seen women on testosterone pellet at their gyne office with labs showing very high testosterone levels. They liked it better, improved libido. Are there risks and concerns with pellet, I guess, pellet
Yeah, the
testosterone?
pellets, people do report that. And I do have an article here. It was a debate between some OBGYNs about pellets in general. And the one that they feel most comfortable with is testosterone, to be honest, because the others, estrogen will stimulate the uterus, cause bleeding, all kinds of things. Women report boost in energy with the pellet, increased libido. The risks of testosterone. which are there's the cosmetic risks, but there's also the health risks related to elevated cholesterol, in particular. So as long as they're aware of those risks, then, I think it's mixed. I don't know what the data says about how effective it is, but if a patient comes in, and like I said, there's a huge placebo effect related to testosterone. So if that's what's happening and that patient feels better, then you just probably need to look at her lipid profile periodically to see, uh, because those are, if they're high levels and they fluctuate. So that's the problem with it. It's not so predictable like a different form of giving testosterone. It'd be really great if they had like a testosterone patch, which I believe they have in Europe, but they stopped the study on it years ago because of the increased risk of, elevated cholesterol, cardiovascular disease. So that was the end of that, and they haven't gone back since.
And I'm assuming the testosterone dose is way less for women.
Yes, it is. So if you were to use like the androgel or whatever, it's a tenth of the dose. Or there's a compounding, I use compounding pharmacies and have the patient apply it. And it's dose dependent. So the more they use, the better they feel. But then there's more side effects. And some of them are permanent. If they have voice changes, the male pattern hair loss, I start telling patients that, you could get a mustache. And they're like, you know what? It's fine. I'm fine. So but you do have to counsel them about what testosterone can do. And then if they still want it, then it's up to them.
I was just going to add that to Kurt. The voice changes are not reversible when you discontinue testosterone. So those women who are super therapeutic, I wouldn't, I mean, it scares me to leave them there. Can I ask you a quick question, Layla? Is this correct guidance? Because when I did the ACP internal medicine update, every single question from the internist was about menopause hormone therapy. But
Wow.
do you think it's safe to say that the oral micronized progesterone is based almost eliminating that increased breast cancer risk that we used to see with medroxyprogesterone acetate, where it's like, I know that Stephanie Falbian always says it's the equivalent of 2 glasses of wine a week or other modifiable lifestyle changes. So do you believe that the breast cancer risk is even lower now that we're using oral micronized progesterone at night?
I do think that breast cancer is lower, but I don't think it's gone away. And this question came up with Darcy Spicer, who you all probably know, in breast in oncology. He had a patient who's high risk for breast cancer, can't be without hormones. So she came to me for an IUD insertion. So I was talking to him like, well, which one is better? And he's like, they all cause breast proliferation. And I asked, does micronized progesterone, does it cause less? He's like, no. And so it is decreased compared to medroxyprogesterone, but it's not zero. So we have to they still have an increased risk of breast cancer. It's just longer period of time. So maybe after 7 years of use as opposed to 5 years of use. That's the difference.
Um, does anybody else have any other questions or I have one. What's your go-to perimenopausal birth control?
I like either low estrogen, like 120. So that's the estradiol and northindrone. Yeah.
Okay.
That seems to be well tolerated, or or Yaz. So either way, I like the 20 microgram pills. So those are the two that I will often prescribe, depending on the patient. I don't go to the 10 microgram. That's just too low, and they can have a lot of breakthrough bleeding. But 20 seems to work pretty well.
Got it. Anyone else? I can't see if hands are raised or much.
I think they just needed the question again, but I'm sending it in the chat.
Oh,
Or you
okay.
could just unmute and ask a question. I mean, we could do that,
Yeah,
couldn't
we
we?
could do that.
No, the MOC question, sorry. The
Oh,
question for the credit. Um, I'm just putting it in there.
Oh, Dr. Ward had a question. Is coronary artery disease contraindicated? Do we need to start screening prior? And I I kind of remember you saying that too, with the woman with the third question, the woman with possible angina,
mhm.
what about coronary artery disease, especially if someone's older than 60?
Yeah, so I think that's where you use that risk calculator. I mean, do you all use that? because I don't, I
Yes.
haven't, but that's what's looked at for a decision I mean, you use it for other reasons, right?
Yes.
So depending on where they fall in that is where it would guide you. So, this patient, because I didn't really think she had it, I was kind of okay. But if somebody clearly did, that would be a different story. I wouldn't prescribe it at all. But for someone else, like you said, before you started, especially if they're older, I would do the risk calculator, whichever one you use, and then go based on that.
So if they were
Ha-
less than 10, less than
Mhm.
5%.
Yeah. So,
Okay.
and the main thing with that is that it seemed that if they were less than 10, but greater than 5, that you definitely would want to do transdermal estrogen.
Got it.
Whereas lower, you could choose between oral versus transdermal.
Okay.
I have one last question, if I can, Leila. This is Mabel
Mhm.
Vasquez. In terms of deciding because there's the Climera Pro, which is the
Mhm.
transdermal, both
Right.
estrogen and progesterone. But some folks do the transdermal estrogen, but they do the prometrium as a pill.
Right.
When do you decide one versus the other? Because I know patients really like the convenience of just one patch, without a pill.
I mean,
Did you address that? And I totally
no,
missed it.
I just listed it as there's Climera Pro and Combi Patch are the two combination patches, which is a
Mm-hmm.
great idea. But I have a hard time when I do prescribe it, it's all on back order. But I mean, it really depends on the patient, what they want. The problem, I think Climera Pro is Provera. So if I'm thinking about breast cancer reduction risk or less of a risk, then it's still better to do Climera patch with Prometrium pill, because that doesn't exist in transdermal form. But it's still approved, and if that's what the patient prefers, I don't really use it that much, mostly because it's been so hard to get. I just stopped prescribing it. Combi patch is a different progesterone. And that seems that a lot of patients were doing great on that, and that also became hard. But you could do it if you can't get it, and that's what the patient wants. Then I would do it. It really depends on what she wants. But I think if I were just strictly speaking concerned about cancer risk, I would really try to avoid medroxyprogesterone.
Okay, thanks.
I also feel like that is the culprit for causing a lot of irritable mood and issues. So I don't use it very much at all.
All right. I think that will bring us to 1 o'clock if no one has any other questions. And we'll be sending out the review article to everyone that you shared from
The Green Journal, yeah.
yeah. And we all appreciate you being here and sharing your expertise
So
with us
hopefully you all
today.
love menopause now after.
Totally.
And if you're not in it, one day you'll join the club and it won't be that bad, I promise. So,
All right. Thanks
okay. Thank
again.
you all so much. Great to be with you today.
All
Take
right.
care.
Bye.